Thank you, David. We move to the last talk of the day. We're introducing Dr. Mansouri, professor from the University of Colorado, as well as from Lausanne, and he's going to talk to us about tonometry. Should home tonometry be recommended?
Thank you again for the kind invitation to speak here, and pleased to give the last talk of this wonderful day. Home tonometry, are we ready? Should we use it? These are my disclosures. Well, it was no one else than the eponymous founder of Goldman Plantation Tonometry, who was well aware of his shortcomings, even in the 50s, and who would be very surprised today if he had been here to see that it's still our gold standard, and we debate alternatives to it. One of the shortcomings is that it gives us snapshot measurements of IOP, and we know how variable IOP is, and a host of different intrinsic and extrinsic factors influence our IOP measurements. As a direct consequence, probably we measure peak IOP, which we believe is correlated to glaucoma progression in about 50% of our patients or more. And another 50% of our patients progress or develop glaucoma at what we consider to be normal IOP values. One reason is that contrary to these flamingos from San Diego Zoo, when we go to sleep, we change our body position. They don't. And it was shown that in healthy normals, young or old, in glaucoma patients, the highest IOPs on average are measured at nighttime and not during the day. However, contrary to averages, patients are individuals, and not everybody exhibits the same rhythm that has been shown in studies. Therefore, it was aware to our, again, forefathers that we needed to obtain round-the-clock home tonometry for our patients, even in the 50s. However, for obvious reasons, these technologies were not further pursued back then. When I was in San Diego, we had some patients who had acquired their own devices that they would use at home to measure the IOP. What you see on the left-hand side is one of the first eye cares, which was not developed for patients, but they could use it with this adapter measure eye pressure. It's very difficult to obtain and not very reliable, probably as an alternative, as a consequence. Today, we have the second generation of the home tonometer, which is a rebound tonometer that some patients purchase. Some services exist to borrow it to them for a few weeks to measure IOP at home. It is worldwide. It is available worldwide. It's available in the US. It is safe to use. It is relatively feasible once patients obtain a training to instructed how to use it to perform at home. It is relatively accurate when measured and compared to GAD. However, it's not very cheap. Not everybody can afford it. And the main limitation is that it doesn't provide you sleep data. And also, contrary to what the promotion of the device sometimes suggests, not everybody can use it very easily in the midst of a meal or while sipping champagne in a business class seat in the airplane, as on those promotion material. It is, however, widely used, at least by engineers. I have several patients, for example, this patient here, who are engineers and who love it and who obtain the measurements many times a day and who present them themselves in different software formats that you can see here. This is a patient who is an engineer from Uzbekistan who came for surgery to Lausanne and has his own eye care, measures them and sends them to me every week by WhatsApp and expects to have an analysis the same week. Another engineer patient, these are his own measurements obtained in the month of July 2020. By the way, he continues obtaining them, again presented by him on a different software program, kept in the local language in Lausanne. So excuse my French here on the slides. What you can see is that he calculates means, averages, standard deviations, and so on, plots them. Here, he decided by himself to change his slit position as he explained on the slides, make sure he's in one position or the other, he doesn't move. He looked at head position. He put it all down, as you can see on this graphic. So engineers love it for sure. Regular patients, maybe less. However, in this nice paper by Andrew Tatum, who also did his fellowship at UCSD and who is very conscious of this question of home monitoring, they included 100 patients, 67 years of age, so reflecting our average glaucoma population, and we're interested to see if they can obtain reliable measurements compared to investigator-obtained eye care measurements. And they found that this was largely the case, as you can see in these graphics, although there was a difference relatively to investigator-obtained measurements. And on average, the measurements were 2.7 millimeters lower than obtained with GAT. When they asked patients about the ease of using the device, it was acceptable. 71% of patients thought that it was easy to use. In a different paper, the same group showed that about 1/3 of patients, despite instruction, were not able to obtain any reliable measurements. So the majority of the patients can use it, but not everyone. Other approaches have, of course, been formulated over the years. You are familiar with the triggerfish contact lens presented here, which back then in 2011 even made the headline of The Economist because it was a technological breakthrough, the first smart contact lens ever. A lot of data was obtained about it on the safety, reproducibility, and efficacy over time. This is a presentation of the measurements that it provides you. The problem was and remains that measurements are not presented in millimeter mercury, but in millivolt equivalents, very hard to use clinically by most people. Nevertheless, FDA approved it, giving it an indication that made its use almost impossible. Essentially, it was approved to be used to obtain the timing of peak IOP, which then would need to be verified by standard tonometry speak GAT. Since peak IOP usually occurs at nighttime when the patient is asleep and ophthalmologist, this was just not feasible and the device didn't make any commercial breakthrough. Nevertheless, it was shown to be useful clinically. This was done by Gus de Moraes and the New York team. They found that in a cross-sectional manner, measurements obtained were correlated to past progression on visual field. So we come back to the question of biomechanics coronary hysteresis. So the fact that this contact lens could measure ocular circumferential changes probably reflects an eye structural vulnerability to glaucoma or glaucoma progression. Another device, and this one an implantable sensor that measures IOP in millimeter mercury, was developed by a German startup company. Two different types. One, the iMate IO. It is created to be implanted in the ciliary sulcus during cataract surgery. The other one, the iMate SC, created to be implanted into suprachoroidal space as part of glaucoma filtering surgery, have been available in Europe commercially for several years now. We published the first in-human study of the suprachoroidal device several years back, where we could show that the device was safe. That was a multi-center study between Germany and Switzerland. Here you can see the anterior and web source OCT images of the device implanted into the supraciliary sulcus to create an opening, to keep it open, as we usually do with a space maintainer in this type of surgery, but more importantly, to be an active, intelligent space maintainer that measures IOP. So the patient went home and he could obtain those measurements, which then were remotely given to the physician. So this is very helpful. And we compared the long-term results after 3 years, not published yet, but this I can share them with you. We found that the device keeps working beyond the first year, up to 3 years and hopefully longer, and that the measurements compared to GAT are very similar. In fact, 95% almost of measurements were within ±5 millimeter mercury of GAT. This is what FDA requires for a device to be deemed comparable to standard tonometry. And it remains safe after these years. Now, this is an example which I think is interesting. You see, I showed it in the morning, you see how variable measurements are in a glaucoma patient. This was not the SC, but the first generation, the sulcus implant. And you see between 2016 and 22, measurements all over the place, going from 10 to almost 40. Those were deemed too high, especially towards between the year 21 and 22. On average, they were around 30, and therefore the decision was taken by the physician to implant a preserved flow, and that's when you see the big drop of IOP. So clearly, the preserved flow works. There are different ways to make this magnitude of measurements a bit more visible. For example, here, they were color-coded. The bluish colors correspond to lower pressures. Between blue or green correspond to pressures between 18, dark blue to 7 to 12. And what you see, especially in the graphic, the lower graphic where we put them by week, you see that the reddish tones in the first 2/3 of the study period became green to blue after preserved flow implantation. Again, a way to make this magnitude of measurements more visible. These are 4 different cases of 4 different patients to show you how snapshot IOP measurements do not really reflect how IOP behaves. Start with the upper left one. The red dot, there's one red dot up there. This is the GAT measurement that was obtained during the day, while the patient had 24-hour measurements with the iMate. And you see that the GAT would give you the pressure 24 or so, like 34, while the real measurements were much lower. So it can give you a falsely high IUP reading. The opposite example is presented below, where the red dot gives you a pressure of around 16, while the real pressures measured for 24 hours are more than that. In the other two examples, you see that the red dot, the GAT measurement, is in the middle of what the iMate measurements would give you. The idea is to let you see visually in actual patient examples how snapshot measurements cannot be representative of real IUP behavior over 24 hours and longer. Now, the patients who obtained this iMate sensor in the eye, did they think it useful? Did they measure? Because you need to obtain measurements yourself every time you want by bringing the handheld reader close to your eye and pressing the button. Well, the first 350 days, they were part of the study and they were requested to obtain at least 4 measurements, which they did. But once the study was over, did they continue? Well, they did. Here we go up to day 950, and you see that the number of measurements obtained per day usually remain between 4 to 5 per day. So patients think that this is useful for them. And when they were given questionnaires, they would say, for example, 73% of them were now more motivated to use the glaucoma drops. Why? Well, because they would put a drop, measure IUP, and then measure 1 hour later and see the effect. So something that's abstract for them, IUP, now can become more tangible when they can self-measure their IUP. So to me, that's one of the more important findings because it shows you that availability of self-tonometry can increase adherence. That's another interesting one. They were also asked whether they were less worried about missing peaks, and 82% of them were now less worried to miss IUP peaks. That comes into improved quality of life for patients. So better adherence, better quality of life. So these two variables may potentially be even more important that if we as physicians can improve management by having the data, patients feel more secure, they use the drops better. These are important points. 4 lessons that we learned from the data, just very briefly. What we see is that in even stable glaucoma eyes, IUP is very unstable over 3 years. Just choose any day and you see that IUP goes from 5 to 20, 25 or more. Lesson 2, we found now looking back at our treasure trove of 92,000 measurements from 15,000 plus measurement days in 22 eyes. So the biggest data collection ever probably, that IUP over the short term is only moderately repeatable. The ICCs were 0.5 to 0.6. So even for a period of 3 months, it's not very repeatable, meaning doing even a contact lens for 24 hours is not enough. You need to have continuous IUP measurements. What about over the long term? Well, of course, over the long term, your repeatability is really further reduced. Lesson 3, we found that at least in this group of mostly retired patients, there was no weekly pattern of IUP. In active patients who have to work, it may be a different story. What about periods of the year? We published this data 2 years ago, and we found that there is a significant reduction of average IUP in summer months. So that may have practical consequences for pharma studies that look at small millimeter changes, and then you would need to consider whether those were done in summer or winter, are they comparable, if they are not. So there's a lot you can do by having this data at your fingertips, and you can really study fundamental glaucoma questions. And finally, other technologies exist, although no clinical data have been published yet. More recently, this approach, the inject sense approach, where you inject a small sensor through the pars plana, has been announced to start a clinical trial in Chile. So we expect the data, hope that they will be positive, and we will have other approaches available to us soon. So to conclude, what can we do today? Well, we can do a diurnal tension curve, usually between 8 to 6 p.m. It has the disadvantage of being time intensive, space intensive. Patients usually remain in the clinic. Do we get enough data? Well, I made the point that we don't, although it's better than a single measurement a day. We don't obtain data on patient activity, patient behavior, and of course, no nocturnal data. And also what we consider to be a diurnal tension curve for many of patients resembles more of a diurnal torture curve because they lose a lot of time, and it only gives us a couple of dots in that dark sky, which is continuous IUP behavior. What else can we do? We can do home tonometry. As mentioned, it has many advantages, but again, it has some important limitations as well. And not every patient can perform it, of course. We have the contact lens, at least in some European countries. But again, it's not IUP real IUP. It doesn't provide me with the mercuries for now. It is expensive. And it's only one session, which is most likely not enough. But again, better than snatch-up. I think the way to go would be an intraocular sensor. Some approaches exist. Some of them are available to select patients in Europe, but they need to become more routine. So to conclude, we can offer home or continue IUP monitoring in patients. It will improve management, I hope. It will definitely improve patient adherence with drops, as we saw in that questionnaire. It will take away patient fears, improve their quality of life. Important limitations remain. We need to be sure about long-term safety of anything that we implant into the eye. We get a lot of data. Until a few years ago, I would say that's a big challenge. How are we going to interpret 100,000 IUP measurements for a single patient over 6 months? We couldn't. But now with AI and machine learning, we can. And I think this challenge is the easiest to overcome. And once we overcome this and can show clinical utility, I think the last one, reimbursement, will not be any major issue. Payers will pay for it because they will see that it saves patients not only time, but precious nerve fibers. Thank you very much for the invitation.